Let us have a detailed look at the stapedial reflex. When presented with a high intensity sound stimulus, the stapedius and tensor tympani muscles of the middle ear contract. The stapedius pulls the stapes of the middle ear away from the oval window, and the tensor tympani muscle pulls the malleus away from the eardrum. This reflex decreases the transmission of vibrational energy to the cochlea, thereby protecting it. It also prevents excessive movement of the tympanic membrane too, via the action of the tensor tympani. The acoustic reflex normally occurs only at relatively high intensities. Reflexes may be elicited at 500, 1000 and 2000 Hz using 110 decibel hearing level. The amplitude of the reflex, latency and timing can be quantified. Typical reflex latencies in normal subjects are 107 milliseconds, ranging from 40 to 180 milliseconds. Normally, the reflex does not decay. What is the probe tone used? Generally, a 226 Hz probe tone is used unless neonates are being tested, in which case a high frequency probe tone at 1000 Hz is used. What is acoustic reflex threshold or ART? The acoustic reflex threshold is the lowest intensity of an acoustic stimulus that elicits an acoustic reflex result, that is, a measurable change in acoustic emittance. A change or deflection criteria of 0.03 is usually taken as the minimum change required to confirm the presence of a reflex. An acoustic reflex will most likely be elicited if all of the following conditions are met. They are normal middle ear function, loud enough stimulus to elicit the response, no abnormal adaptation to the stimulus, and 5% of the adult population, one must remember, have absent acoustic reflexes. What is the pure tone intensity range to elicit an acoustic reflex? The usual range is 70 to 100 decibel hearing level, with a median at 85 decibel hearing level. Ipsilateral acoustic reflex thresholds in patients with normal hearing are usually 70 to 80 decibels above their pure tone thresholds and 5 decibel greater for their contralateral threshold. That is, if the pure tone thresholds were at 10 decibels, one would expect the ipsilateral ART between 80 to 90 decibels and a contralateral between 85 to 95, since the contralateral is 5 decibels greater. Acoustic reflex measurements are usually conducted at 500, 1000, 2000 and 4000 Hz. Results are variable at 4000 Hz, and many normal hearing young adults have elevated ARTs at this frequency. Therefore, results should be viewed with caution. Some clinicians prefer to use a broadband noise as an alternate stimulus to 4000 Hz. Acoustic reflex measurements. Acoustic reflex measurements involve presenting a loud tonal sound to elicit a reflex response from the stapedius muscle. As acoustic stimulation to one ear causes reflex contractions in both ears, we measure both the ipsilateral and contralateral reflex pathways. This is done using both an emittance probe, which is the same one used for tympanometry, and a earphone insert phone. The ear with the emittance probe in it is called the probe ear, while the ear receiving the stimulus is called the stimulus ear. For ipsilateral testing, the probe ear and the stimulus ear are one and the same. That is, the stimulus and measurement occur in the same ear. For contralateral testing, the probe ear and the stimulus ear are different. That is, the stimulus is presented to one ear while measurements occur in the opposite ear. If ipsilateral testing is used alone, retrocochlear disorders, namely intraaxial brainstem lesions, could be missed, and therefore it is preferable that both IPSI and contralateral testing be done. We shall study the terms employed. The correct way to refer to the measurement is based on which ear is stimulated by the loud sound. If the left ear is stimulated by the loud sound and measurement also occurs in this ear, it would be a left ipsilateral acoustic reflex measurement. If the stimulus is presented to the left ear but the reflex was recorded in the right, it would be called a left contralateral reflex measurement. A few contraindicators to reflex testing are tinnitus, outer ear infections, severe recruitment, and hyperacusis. Let us study the ipsilateral pathway. The ipsilateral pathway can best be explained as follows. The loud sound travels through the outer, middle, and inner ears, then along the vestibulocochlear nerve, that is the seventh nerve, to the brainstem, arriving at the cochlear nucleus. From here, the signal travels to the superior olivary complex and to the seventh nerve nucleus. The signal is then sent down the seventh nerve, causing contraction of the stapedial muscle. This is a diagrammatic representation. I repeat again, the ipsilateral pathway can best be explained as follows. The loud sound travels through the outer, middle, and inner ear along the vestibulocochlear nerve to the brainstem, arriving at the cochlear nucleus, from where the signal travels to the superior olivary complex and to the seventh nerve nucleus. The signal is then sent down the seventh nerve, causing a contraction of the stapedial muscle. Contralateral pathway. In the contralateral reflex pathway, the loud sound travels through the outer, middle, and inner ear along the seventh nerve to the brainstem, arriving at the cochlear nucleus, from where the signal travels to the superior olivary complex, the seventh nerve nucleus. The signal is then sent down the seventh nerve, causing contraction of the stapedial muscle. This is a diagrammatic representation. In the contralateral reflex pathway, the sound travels through the outer, middle, and inner ear, then along the seventh nerve to the brainstem, arriving at the cochlear nucleus. From here, the signal travels to the superior olivary complex, seventh nerve nucleus, and then sent down through both seventh nerve on either side, causing a contraction of ipsi and contralateral stapedial muscle. Let us now look at the procedure for obtaining acoustic reflex thresholds. First, tell the patient that they will hear some loud sounds in either ear. Ask them to sit still and quiet. Place the emittance probe into the ear to be tested. Place the contralateral probe into the other ear. Perform temperametry first. Acoustic reflexes should be measured with the ear canal pressure set to obtain maximum compliance in the presence of a 226 Hz probe tone. Depending on the required outcome of testing, it is not recommended to go above 105 decibels unless one suspects a conductive loss. Present tones at 0.5, 1, 2, and 4 Hz, starting from 70 to 80 decibels up to 105 decibels in 5 dB steps until an acoustic reflex threshold is obtained. Tones should be presented for 1 to 2 seconds in duration. If the tone is loud enough and a contraction of the stapedial muscle occurs, the emittance probe will record that acoustic reflex is present. The presence of a reflex should be confirmed to rule out artifacts. Confirmation of a reflex can be done by repeating presentation at the same intensity levels or testing for a reflex 5 dB above the acoustic reflex threshold obtained. Record the results. If there is no response, either enter X or NR or a downward arrow with a 105 indicating no response up to and including 105 decibel hearing level. This indicates to the reader what intensities you have included in your testing. Look for the presence or absence of the stapedial reflex, an acoustic reflex threshold, acoustic reflex decay or adaptation if it is tested. We shall now look at various patterns. If the probe tone is in the right ear and the stimulus is in the right, we find that the acoustic reflex threshold is about 85 decibels across all frequencies. And in the contralateral ear, because we said it requires 5 decibels more to stimulate, we find that the acoustic reflex threshold is 90 dB. Conductive hearing loss. Acoustic reflexes will be absent when a probe is placed in a ear with a middle ear disorder. This is due to the fact that middle ear disorders typically prevent the probe from measuring a change in compliance when the stapedius muscle contracts. Reflexes will therefore be absent even in the case of a mild conductive hearing loss. In the presence of a type C tympanogram, depending on the degree of negative pressure in the middle ear, reflexes can either be present or absent. If acoustic reflexes are present in the probe ear, it is unlikely that a conductive hearing loss exists, except in the rare case of a superior semicircular canal dehiscence.